Mood Stabilizers and Bipolar Disorder, created by Messiah McDaniels, Molly Barrett, and Paige Hildebrandt. This presentation will overview bipolar disorder, a typical treatment course for an individual diagnosed with bipolar disorder, and with a significant emphasis on pharmacological treatment.
Bipolar disorder includes manic episodes, hypomanic episodes, and major depressive episodes. When distinguishing between bipolar 1 and bipolar 2 disorder, a clinician must consider whether or not the individual has ever experienced a manic episode. At least one occurrence of a manic episode, current or past, is necessary to meet diagnostic criteria for bipolar 1 disorder. An individual may be diagnosed with bipolar 2 disorder when they have a current or past history of both hypomanic episodes and depressive episodes. In order to qualify for a manic episode, an individual displays a change in mood and energy that severely impacts important areas of functioning, such as work or social life. Symptoms must occur all day, every day, lasting at least 1 week, and have 3 or more of the following. For example, an individual with a decreased need for sleep can be seen as a person who only sleeps 2 to 3 hours, yet does not feel exhausted or tired. Similar to a manic episode, an individual experiencing a hypomanic episode displays a change in mood and energy that does not severely impact important areas of functioning. Symptoms must occur all day, every day, lasting at least 4 consecutive days, and have 3 or more of the following.
This stuff builds, and it wasn't like rage, but it was pressure. And pressure from the mania. My head was basically spinning, it was racing thoughts, and there's so many thoughts that you can't see them, you just see this whirlwind. And you want to be able to reach in and pick and pull out one to be able to look at it, but they're moving so fast you can't reach in and pull and pick one out. And so you have this whirlwind, and this whirlwind, as it goes around, much like a tornado, creates pressure. My ears felt full, feel like this pressure is leaking out of my ears, and it's starting to go down to my neck, and I thought, oh my gosh. And of course, as this is all going on, I'm getting more and more anxious. I was getting frustrated and getting mad. As I'm driving down the street, I thought, I need music, because I'll transfer my energy through music to have it disappear.
In order to qualify for a major depressive episode, an individual shows a change in mood and behavior from previous functioning. The individual must have 5 or more symptoms during a 2-week period. At least one of the symptoms is depressed mood or loss of interest or pleasure. For example, an individual with recurrent thought of death may have suicidal ideation without a plan, a suicide attempt, or a specific plan for committing suicide.
You can imagine that if it's hard to get up out of bed and even go to the supermarket and get your groceries for the day, that it can be very difficult to go to work and get all the things that you need to get done, either in your work life or in your personal life. People will report guilt or sometimes feeling like they're worthless. People will also report that they feel like they're either kind of moving in slow motion, which is known as psychomotor retardation, and occasionally people will report that they actually feel jittery, which is known as psychomotor agitation. In addition, people will report disturbances in their sleep, which are most commonly insomnia. So either difficulty falling asleep, waking up in the middle of the night, or waking up earlier in the morning than one intends to. Occasionally, this can be hypersomnia, though, where people are sleeping, for instance, 10, 12, 13, 14 or more hours per day.
Included in the following graph is a baseline representing normal functioning. A hypomanic episode requires the least amount of time in order to meet the diagnostic criteria. A manic episode requires a longer duration than hypomanic episode, in addition to increased severity at a time of 7 days. The minimum amount of time required for a major depressive episode is the longest of 3 episodes, lasting 14 days. Hypomanic and manic episodes require above baseline functioning and elevated mood and energy, while major depressive episodes fall below baseline of normal functioning with decreased mood and energy.
This is the etiology of bipolar disorder. Certain prescriptions and illegal drugs may contribute to bipolar disorder, such as Ritalin and other commonly used medications to treat attention deficit disorder can trigger a manic episode. Impairment in brain functioning may also increase the likelihood of a mood disorder. Bipolar disorder is also considered as a family affair. According to the DSM, there is an average tenfold increased risk among adult relatives of individuals with bipolar 1 and 2 disorder. The hippocampus is the storage house for memories and behavioral inhibition. Those with the bipolar disorder tend to show a decrease in serotonin, which affects the individual's ability to perform memory recall and control behavioral impulses. The limbic system is in charge of emotional behavior. Within the limbic system is the thalamus, which relates to emotional regulation. Evidence has shown that a decrease in the mu opioid receptors affect the individual's ability to regulate mood. These receptors also play a role in activating reward systems in the brain. In addition to increasing the concentration of stress hormones, individuals with bipolar disorder show an imbalance of mu opioid receptors.
Specifically seen during major depressive episodes are abnormalities in reward pathways in the brain. There is a decreased release of the neurotransmitter dopamine, which is related to pleasure among other functions. This would explain why individuals in a major depressive episode experience anhedonia. Executive function refers to a collection of higher-level psychological processes which allow for the organization of behavior. These include working memory, inhibitory control, and the attentional shifting. These processes are associated with the prefrontal cortex. The impairment of the executive functioning has been reported during the manic and depressive states of bipolar disorder.
Numerous neurotransmitters have been hypothesized in playing a role in bipolar disorder episodes. In this video, we will present two neurotransmitters that have been given a large majority of attention in research. Norepinephrine is a stress hormone that causes muscle contraction when released. This neurotransmitter plays a predominant role in our body's fight or flight response when presented with a threatening stimulus, increasing in concentration in the synapse between neurons. A second neurotransmitter that has been seen to play a significant role in bipolar disorder is serotonin. Serotonin is a neurotransmitter that plays a role in numerous functions such as sleep, appetite, sexual activity, learning, and memory. Serotonin is also largely linked to mood disorders. Studies have shown a correlation between low levels of serotonin and depressive symptoms in individuals with bipolar disorder. Various treatments have been used with individuals diagnosed with bipolar disorder. Medication has shown to be a popular form of treatment to manage manic and depressive episodes, but finding the appropriate medication for each patient can be difficult. In the following section, we will discuss common pharmacological treatments used in managing bipolar disorder. Three classes of medication might be used alone or in combination to treat specific episodes of bipolar disorder. Lithium was approved in the early 1970s by the Food and Drug Administration, or FDA, for the treatment of mania. This choice of drug treatment has shown to be very effective, but puts an individual at risk for various side effects. Anticonvulsants have been prescribed to patients as the solo form of pharmacological treatment or in combination with another medication. Although this presentation will only discuss Depakote, Lamictal, and Tegretol as anticonvulsant medications for bipolar disorder, other medications may be used, such as Topamax, Lyrica, and Neurontin. Atypical antipsychotics are not viewed as first-line treatment for mania, but can be beneficial for individuals who have less response to other forms of medication. In addition to Zyprexa, Abilify, Symbyax, and Seroquel, other atypical antipsychotics used to treat bipolar disorder include, but are not limited to, Risperdal and Geodon. Pharmacological treatment for bipolar disorder varies in the way that these medications affect the central nervous system. Lithium is believed to mediate the symptoms in both manic and depressive episodes. During manic episodes, lithium has shown to decrease the amount of norepinephrine in the synapse by enhancing the activity of norepinephrine reuptake into the presynaptic neurons. It is also theorized that lithium has an effect on levels of serotonin during depressive episodes by increasing levels of tryptophan, which is a building block of serotonin. Therefore, lithium helps increase levels of serotonin that are deprived during depressive episodes. Anticonvulsants' original purpose was to manage seizure disorder. When used on individuals diagnosed with bipolar disorder, research has suggested the possibility that these drugs enhance the actions of GABA, which is the primary inhibitory neurotransmitter in the central nervous system. Atypical antipsychotics have shown effectiveness in treating both mania and depression. Depending on what episode the individual is currently in, the choice of which atypical antipsychotic is used differs. Lithium is noted as the most successful single-agent medication for managing bipolar disorder. In the 1970s, lithium became the first mood-stabilizing agent approved by the FDA. The onset of lithium is non-immediate. Instead, patients using lithium do not see changes until 5 to 14 days after initiating lithium drug treatment. Adherence to medication can be difficult due to the delayed onset. For example, full stabilization of lithium takes several months. Some of the most common side effects of lithium include diabetes insipidus, excessive urination, weight gain, nausea, vomiting, diarrhea, and aggravated acne. Other common side effects of lithium include thirst, fine hand tremor, and an increase in white blood cell count, which may lead to leukocytosis. The more chronic side effects when using lithium include, but are not limited to, hypothyroidism, goiter, and kidney damage. It's important for patients and family members to be aware of the signs of toxicity due to the small therapeutic window. Some signs to look out for include lethargy, ataxia, slurred speech, shock, and delirium. Toxicity may also result in coma or death. Precautions must be taken when including lithium as a choice of pharmacological treatment. Issues in relation to thyroid and kidney function may result from the use of lithium. It is important to have both systems checked before beginning treatment. Using lithium can decrease thyroid production. Because of this side effect, thyroid-stimulating hormone levels, or TSH levels, should be monitored. Symptoms of hypothyroidism include weight gain, fatigue, dry skin, and intolerance to cold. Lithium use does not need to be discontinued due to a drop in TSH levels. Instead, TSH can be given to patients experiencing this side effect. Lithium also affects kidney function. Because lithium bypasses the liver metabolism, it leaves the kidney to be the sole operator in charge of excreting the drug. If kidney function decreases, there is the possibility that lithium levels will increase in the body due to the inability of the kidney to excrete the drug fast enough, which puts the patient at risk for reaching toxic levels. Another effect that lithium has on the kidney relates to the amount of sodium that is lost during elimination of the drug. In this case, lithium may remain in the body and lead to toxic levels. This is why monitoring both kidney and thyroid functioning is essential when taking lithium for bipolar disorder. The amount of lithium administered depends on the stage of treatment and varies from one individual to another. In general, anywhere between 600 to 900 milligrams daily, divided into 2 or more doses, is administered. When an individual is experiencing an acute manic state, approximately 1,200 to 2,400 milligrams of lithium are administered. Once stabilized, 600 to 1,800 milligrams per day are given. Blood levels should be monitored closely following an acute manic state to avoid toxicity. It is important to acknowledge the small therapeutic window between the therapeutic dose and toxic level when using lithium. It takes approximately 1 to 1.2 milliequivalents per liter for an individual to see results for lithium. Unfortunately, toxic levels can be anywhere around 1.5 milliequivalents per liter, sometimes even lower.
Depakote is a mood stabilizer which typically works for treating rage and instabilities in mood. Studies have shown it may work quicker than lithium, but unfortunately has shown to be ineffective for bipolar depression. Side effects one may experience are weight gain, dizziness, and coordination problems. Lamictal has been approved for acute maintenance for bipolar and to help in the management of rapid cycling. Lamictal has been shown to be more effective for a depressive phase of mood swings and shown to be effective for mania. With Lamictal, it is important to pay attention to the recommended dosage by slowly increasing the medication over a 6-week period. Side effects for Lamictal can include sedation, dizziness, and in rare cases, Stevens-Johnson syndrome, which presents itself as a rash. Tegretol has been considered the second-line agent after Depakote. It has been shown to be used in the management of grand mal seizures, yet has been unproven to treat bipolar depression. In addition to common side effects of anticonvulsants, Tegretol may cause a reduction in white blood cell count. Individuals range anywhere between 600 and 1200 milligrams per day recommended dosage. Atypical antipsychotics are not considered first-line agents when treating patients. Zyprexa has been used for the acute and maintenance treatment for bipolar mania. Similar to Zyprexa, Abilify is also used for the acute and maintenance treatment in bipolar mania. Symbyax has been used in the treatment of depressive episodes. Seroquel has been shown to be efficacious in the treatment of bipolar depression. Common side effects individuals should look for are weight gain and extrapyramidal symptoms. The daily dosage of atypical antipsychotics range and must be administered to the patient at the clinician's best judgment. Atypical antipsychotics share common side effects and differ from patient to patient.
Here we have included a chart that summarizes the purposes of the 8 pharmacological treatment options we have discussed thus far. As you can see, a majority of the drugs discussed in the presentation are effective in managing bipolar mania, except for Symbyax and Seroquel, which instead have shown effectiveness in managing bipolar depression. Although some medications show improvement in symptoms of both mania and depression, such as lithium, this chart indicates the main purpose for possible medications used in the treatment of bipolar disorder.
The following slide contains a helpful mnemonic to remember the different mood stabilizers and how they work inside the brain. Hopefully this will be a helpful reminder for you later during practice.
Treatment has changed and expanded a great deal since I was first diagnosed. When I was first diagnosed, the only drug that was available was lithium and antipsychotic medications like Thorazine, but lithium was the first drug that had been found to be really helpful in preventing future episodes, future attacks of mania and depression. In subsequent years, there's been a lot of research done, and it gets an absolutely staggering amount of research in terms of understanding the brain and the genetics and many of the psychological aspects of bipolar illness, which is quite wonderful. And along the way, different classes of drugs have been used, drugs that have been used with seizure disorders, the anticonvulsant medications, antidepressant medications, which can be problematic in some patients with bipolar illness, but very helpful in others. So there have been many different kinds of medications developed, but also there's been a lot of research on the effectiveness of combining psychotherapy, particularly early on in the illness when it's most difficult for people to accept the idea that they have bipolar illness and that they will need to be treated for it. And psychotherapy can be particularly effective in that group of people. It's often asked, particularly when people are young or early in their illness, can I be in psychotherapy alone? Will that work alone if I have bipolar illness? And the answer is rarely, very rarely. That mostly medication is the central part of treating bipolar illness, particularly the more severe forms of bipolar illness. So it's critical to get that across, that it is a medical condition that requires a medical intervention. But can psychotherapy be hugely effective and helpful? Absolutely, because the psychological consequences of having such a, potentially impairing illness, but also very painful illness and difficult illness with which to cope. And it affects so many aspects of who you are and how you are, your energy, your mood, the whole way you approach life, your relationships, your work, your ability to concentrate, your ability to think. So it's very important to get it diagnosed correctly and get it diagnosed early. And to, reconcile oneself to the idea that, you're probably going to be on medication indefinitely, but worse things could happen.
At the beginning of treatment, it is essential to administer mood stabilizers to the patient. Lithium would be the first choice of medication, followed by an anticonvulsant, and ending with an atypical antipsychotic if neither of the former reduce bipolar symptoms. Lithium is more effective in the treatment of mania, but may also be used to manage the symptoms of bipolar depression. A combination of medications may also be used, although there is no cookie-cutter way of combining them. Benzodiazepines may be combined with other mood stabilizers for the purpose of its sedating effects. The combination of lithium and Depakote is also a popular option, as it has shown to increase efficacy of managing bipolar mania. When a patient presents with bipolar depression, the combination of lithium and an antidepressant is typically used. Antidepressant medication would never be prescribed as the only form of medication when treating bipolar depression because of its tendency to switch symptoms from depressive to manic. When a patient presents with bipolar mania, the combination of lithium with either a benzodiazepine or antipsychotic may be used. Choosing which medication will be combined with lithium is dependent on the symptoms the patient is experiencing. During the acute phase of treatment, it is also essential to assess for the risk of suicide due to the fact that bipolar disorder has the highest risk of all psychiatric disorders at 20%. When a patient has moved on to the transitional and chronic phase of treatment for bipolar disorder, other options of treatment may be used in addition to medication. The combination of medication and psychotherapy has shown to be effective in managing the symptoms of manic and depressive episodes. Psychotherapies focus on the importance of support systems, coping mechanisms, and working through issues that appear to make life more difficult. Some of the potential psychotherapies used include social rhythm therapy, interpersonal psychotherapy, behavioral therapy, cognitive therapy, group therapy, brief psychodynamic psychotherapy, and marital therapy. Family involvement has also shown to be essential for both the patient and his or her family. Families are provided with support as well as education about bipolar disorder. In these phases of treatment, it cannot be stressed enough for the patient to adhere to medication. Continuing pharmacological treatment with mood stabilizers is perceived as the most essential component to preventing relapse of manic and depressive episodes.